Good morning hocam.
We can wait for the others because there are only 3 people, which is seen on the slide on the screen. If I'm sharing the slide now, for example, would it be possible for the others, I mean, coming to the lesson later, to see the slides again?
I think, yeah, I can share it on WhatsApp group.
Okay. Now I'm sharing the slide. Okay. Okay, John, now I'm sharing and so you can deliver the slides to your friends, okay?
Okay, thank you, Professor.
And okay, now what about the slides? Can you see the slide now?
Yes, we can.
Okay. So today we are going to have a panel, and this panel will be about the atherosclerosis, ladies and gentlemen. Now I'm sure that you're okay, you're fine in this cold weather of Ankara. And now atherosclerosis, I'm not sure what you know about it, but if we I'm going to focus on the biochemical aspect of this pathological event, but my colleague is going to tell about the clinical side and some of the symptoms and the other things related with the atherosclerosis. Okay. And if we will actually define this, it is the level of the cholesterol is related to the development of the atherosclerosis, and this is related with the abnormal cholesterol metabolism. So it can give the cardiovascular diseases and myocardial infarction. So we can just abbreviate the terminology like the coronary artery obstructed disease and the myocardial infarction. These are the number one killers in the world, and it is the reason of the 1/3 of all deaths in the world. So it's the lesion is a chronic inflammatory process, and this process is contains some pathologies related with the vascular endothelial structure and the monocytes, macrophages, migration, and some abnormalities in the smooth muscle cells located in the vascular structure, and some other growth factors and cytokines, and we are going to see the details in the next slides. And it's a disease. First of all, atherosclerosis is a disease of large and medium-sized arteries. So especially the aorta, the biggest, the largest vessel in our body. And it is characterized some pathological procedures like the endothelial dysfunction and the vascular inflammation, and some boiling, some accumulation of the lipids, the cholesterol, calcium, and cellular debris residues within the intima of the vessel wall. And if we talk about a little bit histological part of the to understand it well, this is showing the normal arterial wall, and here it consists the three layers called as the intima of the vessel, and the medial part of the vessel, and the outer part is called it is the adventitia, and especially the intima layers are consisting the single row lines endothelial cells facing the lumen here, and a little bit a subendothelial matrix supporting this this endothelial inner side, and also the basal membrane which of the intima, which is supporting the histological tissue in the arterial wall. And in the atherosclerosis occurs in the endothelial part of the wall of the arterial wall. So it's it's a kind of epithelial tissue. It's a mesodermal tissue, and this endothelial vascular system to feeding this endothelial cells has a very important regulatory role in some physiological and in some pathological events, and it is located between the blood and the vascular wall. And here the endothelial cells has glycoproteins and glycosaminoglycans on its surface layer, and these two molecules are giving the surface a kind of a negative charged electricity, and it's and by this way it possesses these endothelial cells possess a large number of the receptors, since they interact with the cellular and hormonal molecules, and some very important functions on the endothelial cells, like the platelet, thrombocytes, aggregations, inhibition, and the inhibition of some coagulation activation. It provides a kind of surface barrier to prevent the coagulation by means of its fibrinolytic function. And it is providing the exchange to the substances, the nutrients, the compounds between the tissues and the circulation. And it also regulates a stable vascular tonus accordingly, and it also regulates the leukocyte and platelet adhesion in any kind of trauma. And you want to talk about any dysfunction on this endothelial part. It is this endothelial dysfunction is provided by the any imbalance on the nitric oxide system. And here, the nitric oxide is a kind of a neurotransmitter, or the transmitter to provide the vasodilatation and the protection against the vascular damage, and also against the inflammation and thrombosis. And this nitric oxide production is impaired in this endothelial dysfunction, and there is because of that reason there is an imbalance in the relaxation and contraction uh, cycle of this endothelial part, and there are some factors like the endothelial source endothelin 1 and angiotensin and oxidants. These factors are also losing their balances in the body in this endothelial arterial wall. And as we know, there are some classical cardiovascular risk factors like the hypertension and diabetes and the increased levels of the cholesterol, hypercholesterolemia. And these important factors are also distracting this protective function of the endothel. And as you see, there are lots of types of hypothyroidism and thrombus activation, and some part of the homocystinemia and diabetes mellitus and hypertension and obstructive sleep apnea syndrome, and they're all deteriorating this endothelial and contribution on the endothelial dysfunctioning, and it is one of the big contributors for progressing the atherosclerosis. Also, the serum cholesterol levels are important in the progression of the atherosclerosis. The increased levels of the serum cholesterol levels, if there is any basement coming from the genetic predisposition, or if there are some also environmental factors can affect it, and there are, I mean, this hypercholesterolemia is might be some maybe sufficient for the development of the atherosclerosis, or even in the absence of the other known classical risk factors. And here the hypercholesterolemia may cause the leukocytes in the blood to bind to this endothelial layer, and in normal conditions this endothelial layer is resistant, is not accepted they did to the binding of this leukocyte. It is resistant to the tight adhesion of the leukocytes. And also the oxidized, we're going to see in details in the next featured slides. This oxidized LDL, low density lipoprotein, also is reducing the endothelial activation and the intracellular concentration of the nitric oxide. And this made some changes. This may have some changes on the endothelial structure, and it causes an inflammation in the vascular wall. So this is creating the first phase in the binding of the atherosclerotic lesions, and from the four phases. And since we talk about the lipids, the cholesterol, as as a reminder, just to understand it better, we talk about lipids and its metabolism. Just a very quick summary. They are as you know, they are the compounds dissolved in the non-polar solvents like the ether and alcohol, and it is the most important components of the cell membrane structure. It's working like the barrier for the cells, and it provides the cell integrity, and also it also provides the vitality and the functioning of the cells, and transporting the materials into the cells, and transporting them out of the cells, and also some other functions like the signal transmission and cellular transmission. And the main parts of lipids in the organism are triacylglycerols. So, in other terms, triglycerides. And almost all of the adipose tissue, the fat tissue, consists of this triglycerides. And as you see, this is the cell membrane structure. This bilayer structure means, especially there are phospholipids as a kind of two layers of lipid molecules, and the cell membranes of most of the cells are lipid layers. And also there are some other parts like we call cell organelles and cell nucleus and mitochondria, and these are all the bilayer lipid structures. And as I said, the phospholipids are the predominant lipids in the cell membrane, and it makes the hydrophobic portion of the cell membrane, and by that way, like the other cell membrane structures are the glycolipids and cholesterol, and also some protein structure, and the hydrophilic parts of the phospholipids are extending to the outer part of the cells, and by that way it interacts with the extracellular liquid environment. So here also there are some intracellular messengers in the form of these proteins, and also these phospholipids are something like to provide the stability of the cell membrane. And lipid classes, as you see, there are the simple lipids, and here the simple lipids are they are the esters of the fatty acids with the various alcohols like the fats, the glycerol esters, and wax. And there are also complex lipids, like it means that there are these are the fatty acid esters, and it contains one alcohol, and another group like the phosphoric acid group, which is added to this alcoholic substructure. So some main examples for this complex lipids are the phospholipids. Phospholipids has contained, of course, the fatty acids and some part of the phosphoric acid, and this phosphoric acid is linked to an alcoholic group, and like the alcohol in this phospholipids is the glycerol, and it is sphingosins, for example, in sphingolipids. For the glycolipids, they contain fatty acids and carbohydrates and sphingosine inside, and some other types of the complex lipids like the sulfolipids and the lipoproteins. And in the lipid classification, as you see, these are the storage lipids and membrane lipids, as we talk about that. And there are some lipid precursors, and these are the fatty acids, glycerol, and steroids, aldehydes, in addition to the sterols. For the lipid derivatives, the ketone bodies, hydrocarbons, fat-soluble vitamins, and hormones. And these lipid derivatives are not charged, and acylglycerols means glycerides, and cholesterol esters are called as neutral lipids. And the structure of lipids, this is the fatty acids, they are the aliphatic carboxylic acids, and they are found in the form of the and or esterified with the glycerols. And as you see on the slide, there is an fatty acids. They have some hydrophobic hydrocarbon chain and a hydrophilic part in this carboxylic acid group, so that the main fatty and glycerol and these palmitic acid, stearic acid, and oleic acid are some types of the fatty acid structures. And as I said, these fatty acids, these lipids are stored in the form of the triacylglycerols, as you see. And if we talk about the digestion and the absorption of the lipid structures, and generally it is about the 80 and 100 gram per day, and more than 90% of this lipids intaking are made up triglycerol. I mean the triglyceride. And the other parts of the dietary lipids are the cholesterol esters, and phospholipids. And as you see here, it is emulsified by the bile salts, and by that way, it is decomposed into smaller fat droplets. And after that, there is a lipase, pancreatic lipase. It hydrolyzes the triglycerides into the monoglycerides and the free fatty acids. And after the conjugation with the bile salts, it is going to the intestinal lumen. So in the small intestine, these epithelial cells are carrying the water in insoluble mold products by means of the help of the bile salts, and there are micelles, which are called the small dots. The micelles are formed, and micelles are able to be absorbed by the intestinal epithelial surface. And here the monoglycerides and the fatty acids are leaving the micelles in the intestinal cells, and then it is passively diffused through the lipid layer on the liminal membranes. And then, as you see, there is a passive absorption. And here these monoglycerides and the fatty acids, the free fatty acids, are combined again into as the form of the triglycerides inside the intestinal cells, and these triglycerides are accumulated, and these are coated like the covered with a protein, with a lipoprotein, which are coming from the endoplasmic reticulum to form the water-soluble chylomicrons in the intestinal cells. And chylomicrons are sent to the outside of the cell through the basal membrane by using the exostosis. And these chylomicrons are unable to cross this membrane capillaries. So therefore, they are first entered before the blood circulation first enter the lymphatic vessels. And this is the digestion and the absorption of the lipids that we had during our daily intake in our diets. And we can summarize the atherosclerosis in 4 stages. The first one is the formation of the foam cells and the progression of atherosclerosis, and in the stage 3, the fibrous proliferation, and the last stage is the advancing of the fibrous plaques within the vessels. And also, sorry. And also, this slide is showing a kind of how this atherosclerosis is progressing, and what is the coordination with some other types of the risk factors and other organs. And first of all, it starts with a kind of damage and a kind of injury in the inner layer, inside layer of the artery. So this damage might be the reason of, as you see, some have some genetic factors, some environmental factors, and the exercise that I'm in the lifestyling. So smoking, this high blood pressure, and the high cholesterol, and hypertension, and inflammation, and obesity, of course, we call as the metabolic syndrome. And they are affecting the many organs starting from the heart, liver, kidney, muscles, immune system, and pancreas. And after that, this cellular or the molecular processes are starting. And it is these risk factors and the genetic factors, and they combined, and they are contributing to the development and the progression of this atherosclerosis. So it involves the interaction of the multiple cell types and multiple molecular processes, starting from the vascular lumen, and going to the media, and the thrombus, and after the laser ruptures, and then it goes on. And in the first stage, this is the formation of the foam cells, and here, so there should be a trauma, an inflammation like the hyperlipidemia, hypertension, and diabetes, which affects the vascular bodies in the organism. So this injury is, let's say, the increased levels of the cholesterol, and it should take, the increasing this hypercholesterolemia should continue for a very long time, and it makes a depositing in the subintimal region of the arteries. So here, the main arteries, of course, the aorta and coronary arteries and cerebral vessels, they are prominently affected by these atherosclerotic processes. Then here, there are some factors like the platelets and monocytes, of course, and here this smooth muscle cells within the vascular wall is synthesizing this extracellular matrix proteins like the collagen, like the elastic fibers and proteoglycans, and they are just in the combination accumulating with accumulated lipids, and by that way the foam cells are forming. And also macrophages are important factors here to contribute to oxidize the LDL, and means the oxidized form of the lipoprotein, low density lipoprotein. And this action, this progress also um, is increasing the injury. It furthers the injury, and these atheromatosis plaques formation is in turn. And as I said, this plasma LDL is mainly catabolized by means of the apoprotein B, and there is it's a kind of a receptor. There are receptors for the LDL, the apoprotein B. And here I would like to say some words about lipoproteins. As you see, it is composed of a neutral lipid core, and in this inner core has the three acylglycerols, triglycerides inside, and some cholesterol esters. It is covered by a kind of shell, like the phospholipids, and it is linked with the unesterified cholesterol, and it is the kind of amphipathic, called as the amphipathic compounds. So here is the outer part is covered with the unesterified cholesterol, and there is an apolipoprotein component also in the structure of the lipoproteins. So this amphipathic property makes these lipoproteins soluble in aqueous solution, and these triglycerols and the cholesterol are carried by these lipoproteins, and this the lipoprotein, the cholesterol and triglycerols can come from the diets, or mostly, and also can have a source from the de novo synthesis, endogenous source. And there are 5 major plasma lipoproteins, and these are as I said, the lipids are less dense than the water, so the density of the lipoprotein decreases as the proportion of the lipid to protein increases. And they are important from the clinical aspect and in pathophysiological aspect. The first one is the CHYLOMICRONs. It is derived from the intestinal absorption of the triglycerols and other lipids. And VLDL, it is derived from the liver for the exporting of the triglycerol and intermediate dense lipoproteins. It is a kind of an intermediate product, and this is formed by the degradation of the VLDL. It is accelerating the fats and cholesterol moving within the water-based solution to the bloodstream. LDL, it is the final stage in the catabolism of VLDL, and this is the high-density lipoproteins. It is involved in the cholesterol transport from the peripheral tissues and also in VLDL and in CHYLOMICRON metabolism. And so here the HDL is the good, as the society knows that the good cholesterol, and like LDL is known as the bad cholesterol. So this is another explanation, so there is not just a reminder. The lipoprotein are organized according to their migration on the electrophoresis. So as you see, the CHYLOMICRONs are in the starting point, and then it goes according to their densities. The last one is the HDL, high density lipoproteins, and in the middle the LDL and VLDL. Okay. And for the lipoprotein classes and the CHYLOMICRONs, VLDL, and their shapes are, first of all, are affecting these atherosclerotic progressions, and there are the CHYLOMICRONs and VLDL and their catabolism residues, and LDL are potential lipoproteins to be predisposing this inflammation, and they are known as the atherosclerotic factors. The LDL and the other CHYLOMICRONs. But here HDL is the opposite, has opposite future, like its HDL is potentially anti-inflammatory and anti-atherosclerotic. And there are apolipoproteins, and these are associated with the lipoprotein particles. They have very important functions, like they have some recognition sites for the cell surface receptors. Some also they are working as some of the activators or coenzymes, or for the enzymes working in the lipoprotein metabolism. And there are some structural components of the particles, and here these are transferred freely between the lipoproteins. These are apolipoproteins, and they are generally investigated in some classes, as you see on the table, and they have some special functions like the ApoA1 and ApoB100 and the others on the slide. And for the CHYLOMICRON metabolism, it is, as I said, CHYLOMICRONs are formed in the intestinal mucosal cells, and here this is this hydrophilic layer, or the hydrophobic. These are made by the intestinal cells, and after that, this CHYLOMICRON remnants is occurred in the by means of the effect of the lipoprotein lipase enzyme, and free fatty acids are occurred and goes to the tissues, especially the muscle and the adipose tissues, and in liver it comes to the liver, and there are some receptors on the hepatic cells, surface of the hepatic cells for the remnant receptors. And for the VLDL metabolism, it is, as I said, VLDL is it is produced in the liver, and it is the predominant factors are the triacylglycerols, and their function is to carry the lipids from the liver to the peripheral tissues. And here the liver, first of all, it secretes some nascent, immature VLDL particles, and here it has some lipids inside, and then it is formed as the apoprotein C2 and apoprotein E are transferred from the HDL, high density lipoproteins, to the nascent, to the immature VLDL, and then here also it degrades by means of the lipoprotein lipase enzyme and activated by the ApoC2, and it degrades the triacylglycerol, the VLDL. And then ApoC2 and ApoA are returned to HDL again back, and here LDL binds to some specific receptors on the extrahepatic tissues. And VLDL are secreted directly from the liver into the blood by the liver nascent particles and containing with the ApoB100. Sorry. Okay. So HDL metabolism, high density lipoprotein, it is formed in the blood by means of the addition of the ApoA1, and it's a kind of apolipoprotein made in the liver and intestine and secreted into the blood. And a little the part also HDLs are also formed within the liver and intestine, and this it is functioning to uptake the unesterified cholesterol from the tissues. And another immature, as you see, and nascent HDL also is occur in the peripheral tissues, and here lasting cholesterol acetyltransferase enzyme is important to absorb the free cholesterol in the peripheral tissues, and here it makes the HDL isoproteins, and by means of the hepatic lipase and CATP, it is absorbed. It is carried to the liver, and it is this cholesterol is by means of this HDL is taken from the peripheral tissues. And what is the role of the HDL in atherosclerosis? This is by means of the lipid peroxidation, it attracts the macrophages, and it is converted to foam cells. And LDL is the principal factor, therefore, in promoting this atherosclerosis. They are accumulated under the endothelial cells. And here the LDL undergoes an oxidation by means of the free radicals released from the endothelial cells, and the local elevation of these lipid hydroperoxides leads to a decrease in the prostacyclin and thromboxane ratio, and it goes to the thrombosis. And in this first stage, in the atherosclerotic processes, as I said, the small part of this LDL lipoproteins, it is degraded by the non-specific uptake of the macrophages, and it induces this oxidative damage of the low-density lipoprotein, and then these foam cells are generated by means of the combination of this macrophage, and these form the hallmark of the atherosclerotic plaques. And lipoprotein small a, lipoprotein A is also important. It's a particle and it's present in the large quantities, and it's a kind of like LDL-like particle. And here the basement is the ApoB100. It is linked with a disulfide bridge to the apolipoprotein A. And this ApoA, the component is similar to the plasminogen in terms of the structure and components with the plasminogen. So it binds to the sites, specific sites, to reduce the fibrinolysis and the formation of the blood clots. And lipoprotein small a is thought to the increased number is the speeding up the process of the atherosclerosis by binding the LDL, calcium, and other components onto the atherosclerotic plaque on the blood vessel wall. So this has a dual function, and that's why its role is important in the progression of the cardiovascular diseases. So high number or highest level of this lipoprotein A is slowing the breaking down of the blood clotings. So by that way, it is facilitating the thrombosis and may lead to the heart attacks because it competes with the plasminogen for binding to the fibrin. And atherosclerotic plaques are generally explained in three types, like the fatty streaks and the fibrous plaques and the complicated plaques. In the fatty streaks, it is formed by means of the accumulation of the macrophages, and these macrophages are filled with large number of the lipid droplets at the intima, and this is the foam cells. And the lipid droplets include the cholesterol esters, and it is coming from the LDL particles. And these LDL particles, as you know, are bound or oxidized or accumulated by the scavenger receptors. But this fatty streaks formation is not able to affect these blood flowing. And in fibrous plaques, so the lipids in the fibrous plaques are found in the macrophage. Foam cells are also in the extracellular matrix, and here the intima is thickened because of the accumulation of the smooth muscle cells and extracellular matrix proteins. Or maybe instead of accumulation, we can say the proliferation of the smooth muscle cells and the extracellular matrix proteins in lipids and macrophages are also located in the nucleus with the T lymphocytes and sometimes B lymphocytes, mast cells. And here there is a fibrous hat, a fibrous cap is formed, which is covering all these structures in the progression of the atherosclerosis. Incomplicated plaques means that it has plaques that have ruptured, that have decomposed, are called the complicated lesions. So here the extracellular matrix of the lesion is broken, and usually at the shoulder of this fibrous cap, fibrous hat, and by that way it separates the lesion from the arterial lumen. And then at some thrombogenic components are migrating to the plaque, like the collagen, and by that way they are all triggering the thrombus formation. And it is the more accepted view, and it proposes the smooth muscle proliferation as in the initial event. So smooth muscles they have contained and the lipid droplets, which is seen in the lesion. So smooth muscles injury may have originated from the lipid peroxidation, Then in the drink, it is in the stage second, this condition may be reversible. And if we are trying to decrease the plasma lipid levels, especially the LDL levels. But if we don't, then the lipid accumulates, the lesion progresses rapidly, and some endothelial changes, some arterial changes, they might be irreversible. So this is the smooth muscle proliferation is the center of the stage 2 in the progression of the atherosclerosis. And if in the stage 3, this is the fibrous proliferation stage, and there are some growth factors which are liberated from the macrophages or platelets, and also there are lipoproteins and glycosaminoglycans and collagen are accumulated. So here also C-reactive protein, high sensitive CRP, is also increased during that stage. And in the last stage, this is the advancing the fibrous plaque. As you see, this is the narrowing of the cell. The inside of the cell wall is started already, and the proliferative changes also may occur. And here, especially the coronary arteries occlusion here may have some atherosclerosis in this coronary arteries may have lead the myocardial infarction. And here the important is this clotting. So the blood flow because of this narrow lumen is more turbulent, and there's always that tendency for its clotting formation. Let's say if this becomes a thrombus, and thrombus may lead to the obstruction of the arteries, and this thrombus may also may be torn from this real original arterial wall, and they can go down or they'll go up to the other tissues, arteries, and they may occlude the other parts of the bodies, like the cerebrum and like the other peripheral vascular system. And this is another show about how especially the macrophages, by means of the oxidating agents like the superoxide radicals, nitric oxide, and hydrogen peroxide, and other oxidants, are promoting the oxidation of the LDA, and instead on the opposite side, the vitamin E, C vitamin, and carotene and antioxidants are trying to decrease the possibility of the oxidation of the LDA. And here there are high affinity receptors for the LDA. When the levels are increased, it is starting to downregulate when the cell has sufficient cholesterol, and this is the foam cells are starting. And there are also some factors coming from the foam cells, releasing some growth factors and cytokines, and they are stimulating the migration of the smooth muscle cells, especially from media to the intimas. And these smooth muscle cells are starting to proliferate, producing collagen and taking up more lipids, and they are becoming more and more foam cells. And macrophages are, as you see, are consuming, if there are increased number of oxidized lipoproteins. So it is a good contribution for the production of the foam cells. And another molecular pathway for explaining the monocyte adhesion, also some other parts like the selectins and integrins are important promoting factors for the atherosclerosis proliferation. And first, monocytes are accumulated in the vessel, And although there are some scavenger receptors, and the CD36 is the important factors. And here, then the macrophages are releasing these particles. The and then these macrophages are with the oxidized LDL becoming the foam cells. And here with the foam cells, there are some other factors releasing from this macrophage, like the ROS, reactive oxygen species, some tissue factors, cytokines, and matrix metalloproteinase, and some lipid droplets. And then these the protease enzymes are rupturing this plaque and this clot formation starting. And then with this clot formation may go to the central nervous system or peripheral vascular system, may cause stroke at the end. And in the atherosclerosis, it is a risk factor for the also stroke. So it is an inflammatory condition. So there must be an injury, the accumulation in the arterial intima by means of the LDL lipids with the ApoB100. LDL is the major carrier for cholesterol in the circulation, and also the ApoB100 has some substitutes like the phosphatidylcholine, sphingomyelin, and unesterified cholesterol with a different percentage. So it constitutes a surface. It surrounds a core of the cholesterol esters and triglycerols. So this is the if you say the traditional view, as I said, the deposition and accumulation of cholesterol and other lipids, and there is a cellular debris within the wall of the arteries, especially the medium arteries and the large arteries, is formed, and it is results in the plaque formation, and it also disturbs the blood flows. And the endothelial injury and the dysfunction also might be induced by many factors, like the also homocysteine and tobacco toxins, smoking, mechanical forces like shearing stress, and some infectious agents. And these are also resulting in inflammatory response, and the oxidation of the LDL in the arterial intima, and the migration of the monocytes in this developing lesion. And this diffusion of these monocytes and the LDA through the endothelial cell junctions into the arterial intima. Here, LDL is accumulated by means of the ApoB100 and matrix proteoglycans. So LDL uptake and retention are becoming increased and increased at the plaque sites, and it involves the degradation and the binding to the cellular and matrix components. And LDL is oxidized to the oxidized LDL form by means of the polyunsaturated fatty acids, and especially this phosphatidylcholine part of the LDA is important to generate this oxidized to form this oxidized LDA. And as I said, these are some adhesion molecules like the selectins and integrins. Also, the inflammation in the progression of the atherosclerosis are producing the stimulation in this expression of these adhesion molecules in the arterial endothelium. So it also stimulates the adhesion of the more and more monocytes to the endothelium. So these monocytes are able to penetrate the arterial intima and differentiate into macrophages, and then the accumulation of the macrophages with the combination with the contribution of the other factors become foam cells. And here there are CD36 scavenging receptors. Here it is also important. And these macrophage foam cells generate the reactive oxygen species, and it produces more and more tumor necrosis factor alpha and interleukins and matrix metalloproteinase 9. So these are all also making some contribution to promote the atherosclerosis and degrading the fibrous cap. And then the plaque is ruptured and goes to the other peripheral tissues. Yeah, and when it goes, the destabilization of this clot may result in the release of an impulse into the bloodstream and can be transported to the brain and other tissues and induce an ischemic stroke. Okay, so the time is up, and this is the physiopathology of atherosclerosis from the perspective of the biochemist. If you have some questions or some other things, yes, please. Okay, if you don't have any question, so see you later. Bye.
Thank you, Hocam.
Okay, thank you, Musa.
Thank you, Professor. Have a nice day.
Thanks, friends.